Conference will now be recorded.
Right, and if somebody could fill in Michael P for caller 01, I'm pretty certain that's who it is, according to Jim Marshall. Jim Marshall.
No problem,
can anybody hear me?
Yes, we can. So hold tight,
Okay,
and
good.
we will get to you. All right. And we can still see you, I think, somewhere else. Yeah, we can see you and we can hear you on the phone. I think what we'll do, since Jim Marshall did sterling work and he produced a cheat sheet for me, for all of us. Would any of you, Jim, or can you do it, Dr. John? That would be fantastic.
Okay.
Excuse me, Dr. John. I don't think his phone is now connected.
Oh,
Can you hear me now?
Yeah, we can hear you.
Okay.
Okay.
So here's Michael.
Okay, great.
Here's what we're going to do. Captain Jim did fantastic work for us and worked with you to get all the information on a cheat sheet. And one of our moderators, Dr. John, has excellent skills in reading these quickly and summarizing, because that's what he did for most of his life. He had to look at notes. And so we are going to employ those skills of his, and he will do a quick summary, and then we'll get into the details with you. I already have a couple of thoughts for you. So, John, please go right ahead for the group.
Michael is a 73-year-old man from New York State who for the last year has been diagnosed, worked up, and started on treatment for prostate cancer. I don't know how it got started. I assume the PSA went up, but he started out with MRI, bone scan. He's had CT scans, PSMA PET scans, and what it all boils down to is that he has polymetastatic prostate cancer, multiple bone lesions, and I think I saw a reference to the lungs. I'll have to ask him to clarify that. He had two completely unhelpful prostate biopsies, which didn't show anything. And he's also had a bone biopsy, which confirmed that particular metastasis. He hasn't had any somatic testing, something we can raise with him since there is some biopsy material. He did have some germline testing, which apparently showed some colon cancer risk, but nothing directly that I know about the specifics. I assume he's a veteran because he came from Jim, but I'm not sure. Medically, I know that he has osteopenia on a DEXA scan done in December. Otherwise, medically, I don't know about his health. And that's it. So questions in mind. I don't know what his questions are yet, but I have questions about tissue biopsies and whether docetaxel would be a good idea. And I'd like to learn more about his PSA history. He found his way after starting out at a local hospitals to MSK, where Dr. Keegan is his GU Med-Onc.
And Dr. Keegan is part of the Irish Mafia at, she's the youngest recruit to the Irish Mafia at MSKCC, because I happened to find a name just a few weeks ago, maybe 4 weeks ago, when I was doing some research for somebody and looking at Dr. McHugh and looking at all the other Irish GU Med-Oncs. They have a long, long tradition of Irish medical oncologists coming over from Trinity, Dublin, and other hospitals to train at MSKCC. So, John, why don't you keep going? You're on a roll there.
That's all I got.
Okay. So, let's first check with Michael. Did we miss anything out, or is there anything you would like us to raise that we didn't raise?
Okay, as long as you can hear me. I am not a vet, first of all. Not sure if that matters, but I am not.
Yeah.
I never served. Worked with a lot of veterans, but never served. Yes, my prostate, my PSA was up. This whole journey began about a year ago, January, with a PSA of 8. I had 2, as was indicated, ultrasound biopsies. Nothing was found, and the PSA continued to go up to its highest point of about 81. I did have the MRI of prostate. The lesion could be seen there, but the provider I was seeing said it's not your prostate, and see me in 3 months. I didn't go along with that. I did something else. Obviously, I'm here. Other than that, I think most of what you read was about, a good summary of what's going on.
And when did your PSA hit 81?
July, I believe, July, August.
Okay. And then when did you start, when did you actually, you started treatment?
December 17th.
You didn't start treatment until 12/31. So what happened between that period of time?
Okay.
I mean, you were obviously finding your way to Memorial Sloan Kettering, but there's like 6 or 7 months between trying to get to Memorial Sloan Kettering and starting treatment.
Right. Well, in the last time I saw the urologist I was seeing was August, and he instructed me that it was not my prostate and that I should follow up with him in 3 months. I wasn't comfortable with that, specifically because the MRI had 2 very specific findings, and he didn't seem to feel it was appropriate to address them. I don't know. In September, I went to my primary care doctor. She ordered the bone density, and we at that time decided I was going to go to a local orthopedist. The local orthopedist sent me to a orthopedic oncologist. That was in October. By the time we get to November, I had the actual bone biopsy, and November 17th, my world changed. And then on December 17th, just happens to be the same day, after I had met and had my initial visit with Dr. Keegan at MSK, which the first time I went was November 28th, day after Thanksgiving. I started the biculitamide on December 17th. So just to
Right.
get that order, treatment started then. Now, December 31st, I had my first Lupron injection, and now I'm on the abiraterone and prednisone.
Got it.
As well.
Got it. So a couple of things I would say initially is, did you discuss with Dr. Keegan using Orgovyx instead of abiraterone, instead of
No.
Lupron?
No, I didn't. I don't know anything about that medication, so no. The answer is no.
Okay. Well, it's a.
What would be the rationale, the one as opposed to the other?
So the Orgovyx is a comparable medication to Lupron, but it's a much superior medication. And if you can get it, you're better off on it. First of all, because it's a daily pill, it's not an injection.
Oh.
And if there is any chance that you will at some point be coming off of the hormone therapy, which won't be immediate, but you do a lot better. And you do a lot better when you come off of it. And the other thing is, some men, although there's no really strong medical reason, but some men suffer less side effects. The only possible less side effect we can definitely attribute is that there are less cardio issues. Do you have any cardio issues?
No. My blood pressure is barely 120 over 75, okay. Pulse about 60.
Great.
No cardio issues that I'm aware of.
It's just a better medicine.
Can I get the spelling of that?
Yeah, somebody will put it in the chat window for you. Somebody will put it into the chat window for you. It is a much better medicine, and it sort of bothers me that the GU medical oncologists are not looking to prescribe it initially. That Steve Roux put it in there. That is the commercial name. The generic name is relugolix. It's been around a few years now. It's just a better medicine. How many lesions in total do you think you have?
I believe there are 5. I thought I noted that here, but I guess not. PET scan, here we go.
I think there may be more than 5 from what little I saw.
Right proximal humerus, T6 vertebral body, left posterior acetabular column, left superior and inferior pubic rami. Yes, so this was 6. And the I believe it was mentioned before, but I just want to make sure the record is straight. When I had the PSMA PET, the same day they did CAT scans of the chest, abdomen, and pelvis, and there was nothing in the abdomen or chest. So lungs were clear, the rest of the abdominal visceral organs were clear, and they noted the same findings that had been on the CAT scans themselves. So yeah, I guess it's about 7.
Yeah, I mean, it depends if we take these, what was seen in October together with what was seen in July, and when was your, and the PSMA was 12/11. I think if it were me, what I would be doing, and that 12/11 saw, how many did we say, 7? 1, 2, 3, 4, 5, 6, 7. With 7 lesions, and I would like some people to, maybe RJ or somebody else, to talk about their own situation momentarily. You could be a candidate, as Dr. John said, for chemotherapy. And we're getting a little bit of feedback from you, Michael. If you could just turn your volume down a little bit on the phone, that might help.
Is that better?
Yeah, I think it is. I would really want to be getting a meeting with Dr. Keegan right away and asking her, should you be on chemotherapy? And also asking her for a second opinion at Memorial Sloan Kettering on that.
Okay, we did, can you hear me?
Yes, sir.
Okay, we did discuss chemotherapy briefly, and I don't want to put words in her mouth because I didn't write it down, at least that I recall, that it was something we would consider depending on the reaction that we got to the hormonal therapy. She, I believe, said something to the effect that she wasn't sure it would improve anything at this time, meaning when we had the discussion. But
So-
we haven't discussed it recently.
The problem is that's not what the trials say. That's not what
I'm
the
sorry, that's not what the,
clinical trials say.
oh, okay.
So the clinical trials say that if you have more than 5 lesions, then you're better off with chemotherapy, starting with chemotherapy than starting off with a drug like you got, Lupron or Orgovyx plus abiraterone or a similar drug. And that's why she may not think that it's going to help you. But if you sat down with, say, a more experienced genitourinary medical oncologist, that would be a good second opinion.
So you're suggesting a second op at perhaps a different NCI site, certified site, or just any other?
Well, I'm sorry, this feedback's making me a little nutso here. Sorry, I'm getting feedback from your from your phone.
Turn down the volume on the laptop.
Oh,
Okay.
yes. Yeah. Thank you. I think that was Steve Roux. Let's see if that helps. I think there are 2 options. I think the first option is you can even ask for a second opinion at Memorial Sloan Kettering. And that's definitely an alternative to consider. I think the other thing to do is to go get a second opinion from another genitourinary medical oncologist. And by the way, that's
I've done that. Okay, good, thank you. I turned down the computer volume. I had a consultation at the local community hospital called Phelps Hospital.
Yeah,
nearby.
You can. Yeah, that's not going to. You can dispose of that one. That wouldn't meet our. What we're saying is go to another center of excellence and get a second opinion. One alternative might be David, I forget his last name, I'll tell you in 1 second, at New York University, NYU Langone, and that could be an alternative.
We also have
I'm going to throw
Albert Einstein. That's an NCI.
No, Montefiore,
no,
not an option. And frankly, New York Presbyterian, not really an option anymore. Well, there's no one we really like so much there who are GU med oncs. There's a couple. There's a woman who's been around. There's a woman there who's been around. She's really a sort of an elder statesperson, but I'm not sure I would go see her. That's just my own preference. I mean, we had good experience with somebody seeing this fellow at NY Langone. So let me throw it open. RJ, how many lesions did you have, and when they decided they wanted to add chemo?
I had 8 lesions that showed up on the PSMA PET scan. Not all of them, although certainly one of them showed prominently on the CT, and they didn't do a bone scan, but they were kind of like, well, it's in between, low volume and high volume. And I would say my medical oncologist put me on the Lupron and the abiraterone right away, just because that's a standard thing that they do. And then I talked to him about the triple therapy. And he also said, okay, like if you're going to go get radiation, then you should talk to the radiation oncologist, and can't do radiation at the same time that you're doing chemo. And you're already fast tracked. I have a really good radiation oncologist. And he was like, let's go. And so then I came back afterwards and talked to my medical oncologist, and he said, well, if you want to do the triple therapy still, you can do that. So he put me on chemo after the radiation. So he said, well, it's a little bit after, and I know I missed last week's meeting, but there was a little bit of discussion on there. Well, if your PSA is undetectable, like how much good is the chemo going to do? And he said, we don't know. So he said, but if you're up for it, it may do some good. And so it's like, do you understand what the side effects are? And that some of them may be permanent. And I said, yes. And he's like, okay, like if that's what you want to do. And so one of the things is, you know, like I just did the research and I advocated for it. And my medical oncologist said, okay, if that's what you want to do, we will do it. We don't know how much good it will do, but you know, if you're willing to accept the harm that it will do, likely it will just be temporary, which, you know, fingers crossed on that. And I'll talk a little bit about my journey thus far. But he said, you know what, like if you've, you know, read piece one and you understand, you know, that triple therapy in a high volume disease seems to, you know, and like how it actually does that is a little bit complicated, but if that's what you want to do, then I'm up for it. And so I said, yes. I think that out of the gate, he kind of said, well, it's questionable what the chemo's going to do. So why do you want to go through chemo when you've gone through all of this other stuff? And I said, because that's what I want to do. And he's like, well, okay, then if you're ready to go, he's like, you're a good candidate for doing triple therapy because, you know, you're young, you're early in the disease, and if you want to throw the book at it, we can throw the book at it. So right. I think it's a little bit, you know, questionable, but, you know, I was kind of like, what's the harm? And let's do it if there might be some benefit.
I think piece one, thank you. Piece one is the trial. Yep. And I think there's a couple of action items for you here. One is to definitely discuss with Dr. Keegan about piece one and why she's not recommending chemo, because we seem to think that this is called triplet therapy. We seem to think that triplet would be right for you with seven lesions. The second thing is to talk to her about what plans she might have to treat the primary. That's the radiation discussion that RJ just had with you. So in the past, we never treated the prostate gland for men who were diagnosed de novo metastatic. But that thinking has changed in the last 4 or 5 years. Most of the time, if it is treated, it's treated with the radiation. Occasionally, it's treated with surgery. But you could be a good candidate for surgery. A lot of times, if they do chemotherapy up front and they do a triplet, they might wait 12 months or so to treat the primary, but it depends on the patient. And, you know, in RJ's case, they're not going to do that. The third thing that I don't see that we would suggest you discuss with her is why she hasn't put you on a bone modifying agent, because you have osteopenia, you're going to be on hormone therapy for quite a while, and you probably, I mean, the standard of care would be to add some sort of bone strengthener, which you would get on a periodic basis. And it looks like she hasn't discussed that. Did she discuss that with you or not?
No, she did not.
Okay, well, she should have done. And you see, again, this is one of the problems that you've got a young doc. And I'm sure she's really good, but she's learning all the time. And we'd rather see you. She is a GU med onc, but we'd rather see you with a much more experienced GU med onc. Most of the time, those people are in the city. There's a couple who are outside, like Chuck Ryan, who does work in the city, and he does work in Jersey. But most of the time, they're in the city, and you just don't get the best docs. You don't get the best docs in the city. Len, do you want to say something about that? Because you know MSKCC pretty well at this point in time.
Yeah, they have so many medical oncologists now. It's hard to keep track of them all. I would hesitate to suggest Danila, but he's been there a long time, and he was a protege of Michael Morris. But I wasn't very happy with him. But that was 10 years ago.
Right. But there's Dana Rathkopf is there, McHugh is there. Although somebody told me they have some. Oh, Ben said he has some feedback on McHugh, and one of the gents in this room tonight sees Dr. McHugh. You know, we've got.
Where is this doctor?
They're in the city. They're in Memorial Sloan Kettering in the city. But it can be very difficult to change horses. So if you ask for a second opinion from a more senior doc, I would probably say Dana Rathkopf is the doctor that I would get a second opinion in your case from. I can put that in the chat window for you momentarily, but I'd say Dana Rathkopf. Okay. And she says, well, I might add chemo. You know, then the discussion is, well, who's going to be running my care? If she says, you know, if you go and see David Wise, which is another name I put in there at Langone, and he thinks that you should add chemo, then you're going to have a come to Jesus moment with Memorial Sloan Kettering and decide where you want to get your treatment.
Well, we did talk about on our first visit whether radiation would be used, and they seem to be focusing in on whether there was pain anywhere, whether any
okay, so let me stop you. Let me stop you. That's a different discussion. So radiation is used two different ways. It's used palliatively if you have pain anywhere. Mm-hmm. But it's also used therapeutically to treat the prostate. And the discussion we're having is not the palliative. That's what they were talking about. Do you have pain anywhere? We're talking about adding, because the old way of doing it, if this is what Dr. Keegan was saying to you, the old way of doing it is you only use it for palliative and for pain. We're saying no. Now, therapeutically, a lot of hospitals will administer radiation therapy to treat the primary lesion.
Okay. So, I mean, clearly nothing stops me from seeking a second opinion at NYU Langone. I mean, right. You know, that's certainly not just my right, but, you know, obviously based on this discussion, at least that would seem to be an appropriate maneuver. Continuing the treatment I'm on, I don't seem to be having any unusual side effects. In fact, I don't, other than maybe a little agitation at times, I don't have any. I don't know if that's good or bad. But yeah, I mean, I can go get another opinion. I don't, you know, we don't have to ask permission to do that, certainly.
No.
That's, you know, that's the advisable thing to do. What the response is, you know, I'll share with you, you know, if I choose to do that at this time or wait a little longer and then do it, I don't know. Okay, I see that in the.
So Dana Rathkopf is at MSKCC as well, and I guess our concern is you don't have a very experienced doc. I'm sure she's very nice, right. But she's young. She's learned, and we would rather see you with a more experienced doctor.
So Dr. Rathkopf is at MSCC in Manhattan. Is
Yes,
that the case?
yes.
Okay.
Greg,
All right, let me know.
unless they changed their policy, remember, MSK doesn't allow switching
No, they
unless
don't.
you've been away 3 years.
No, but we've seen a couple of people manage to switch in Jersey. It's been very, very difficult. The other thing is that I'm thinking that if you got a second opinion from David Wise, and David Wise said, if you were my patient, I would put you on triplet therapy, then you can go back, ask for a second opinion with Dana Rathkop, say, what do you think? And if Dana Rathkop says, yeah, I probably would too, then you can ask to switch.
Right. Got it.
Which
Got
is
it.
sort of a roundabout behind the head way of doing it.
Well, my impression with the MSKCC and Dr. Keegan, who, yes, is very nice, but that's not what this is about. It's not a popularity contest. Was that they work in a team and that there is communication amongst the sites and amongst the, I'm going to say more experienced
Right.
people. I don't know
So-
that's for a fact. I have no way of checking that.
Right. So I'm going to hurry you along. I'm going to hurry you along here because
Go ahead.
you know,
Let's do somebody else.
we're aware of this. What I would say is if she's discussed your case with more senior GU medical oncologists before deciding that you should be on doublet rather than triplet,
Mhm.
then what I suggest to you is find out who it was she discussed it with and come
Got
back
it.
and
Got it.
all right. Otherwise,
Okay.
Because she may not tell you, and she may say, no, you can't get a second opinion here. But let's first of all build a case, and let's find out let's find out. Anybody have any ideas on a GU Med Onc at Columbia Presbyterian? Okay. So, and anybody have anything else they'd like to raise with Michael?
Yeah,
Dr.
just
John
a
has
couple
his
of
hand up.
a couple of small points regarding the question of triplet. I would just like to point out that both the CT and PSMA radiologists doing the readings used the word numerous for the number of METs. So I think we're quite safe in assuming that he's polymetastatic. Then the other thing is for the future, if the question of treating the prostate or debulking the prostate ever comes up, I also wanted to point out that a substantial number of these metastases showed up on traditional imaging, which means they're not tiny. So the definition of high volume disease is also probably met.
Really good. And Michael, you'll be able to listen to the recording tomorrow,
Okay.
or tomorrow, or possibly Wednesday. But you'll be able to listen again, so you'll get all of this. Do we have any other hands? No. And the bone strengtheners, yeah. Steve S is reminding me, and discuss the bone strengtheners with her as well. So bone strengtheners, doublet or triplet, and radiating the primary.
I hate to extend the discussion, but the fact that we have no tissue looked at under a microscope is bothering me a little bit. Is it unnecessary to look at this tissue under a microscope because we've got so much other information? Or would it be good to look at the bone? The bone met itself could be looked at under radiation, and genomic testing, under a microscope, and genetic testing could be done on it as well.
Well, didn't you say the bone mets were looked at under a microscope?
Yeah, if you look at number 7, on my notes, the one bone biopsy, they talk about something called pan-CK and NKX 3.1. I don't know how many needles that was, but Dr. Keegan and staff indicated in their record that they have reviewed the actual pathology slides. If that's what
Okay,
you mean.
excellent.
And that they were concurring with the findings. Now, whether there's anything else that should be done, I don't know.
The only
Thank
other
you.
thing that should be done, and they'll do this in a heartbeat if you haven't had it done, is to check for any inherited mutations. They should have come up, they should have come out. They can say, well, they would have shown up in the bone biopsy. They're 90% right. But
something was done along those lines, Rick, and they told him that he might be at risk for colon cancer.
Correct.
But we don't
Okay,
have the gene name.
Okay,
It's
so
in the report. There's frankly, all kinds of gobbledygook in there, which means absolutely nothing to me, but I'm sure someone who's knowledgeable would get something out of it. But yes,
I mean, what if
the
there's a Lynch
genomic
syndrome
or
in there or
hereditary
something
panel
like
was
that?
negative. And something that they called secondary germline showed this increased risk for colorectal pulposis and cancer. And I noted that all of my colonoscopies have been negative for whatever that may mean.
okay, I do want to move on because we got one other new gentleman to
Sorry
speak to.
to time that
Just
much, but thank you.
keep me on, but
Right,
so
just
hopefully
interject, Rick. I just wanted to raise the possibility of Charles Drake at Columbia Presbyterian.
yeah, he's not there anymore.
Oh,
I don't think so. I'm pretty certain that Dr. Drake is now, he's basically a research doc with J&J, and I don't think he's doing any clinical work.
okay.
He was there and he was very good.
Thank you.
But I don't think he's there, and I don't think he's seeing any. If he is, he's only seeing patients he's been treating for a long while. He's not taking new patients, Gary. Okay, Harry Wessler, you've sort of got the program, except we're going to ask you the questions because you didn't get to. Nobody got to you first to help fill in the information. So let me start with you. If it's okay, can I ask you a bunch of questions here? Your microphone's off. Turn on your microphone. Okay. Yes. Okay. So how did you come to AnCan, Harry?
Dr. Alfredo's a friend of mine from 20 years or so, probably.
Oh, okay. Okay, royalty. All right. And we love Dr. Alfredo. And did you sign up? Are you on our mailing list?
No.
Okay. So either through Dr. Alfredo or you directly, if you would please put your email in the chat window, send it to me or send it to everybody, and we will make sure you get reminders for this meeting each week. We meet weekly. I will also mention to you and to Mike Perillo, Mike, if there's anybody, Michael, if there's anybody you want to reach out to yourself, send them a message through the chat window. We're very proud to say that 46% of our people in this group make friends with other people in the group outside of the group. What is the beauty of that? I will tell you, that was rhetorical. It is that our groups don't finish when the meeting finishes. Because if you're making buddies with other people who have the experience, you can call them up. you can reach out to them. They'll reach out back to you, and they will be helping you even when we don't have a group. So we very, very much encourage you to do that. Oh my gosh. And I just saw that Gaoshan sent me a message. He made a buddy with one of my closest buddies this week. God only knows how the two of them figured out that they were both going to be in Taiwan at the same time, but I will find out. Okay, so Harry Wessler, and you're going to make sure we have your email. And how old are you, Harry?
80.
Okay, and where do you live?
Suburban Seattle.
Okay. So we have some other Seattleans. I don't know what you call them. What year were you first diagnosed?
2025.
Oh, okay, relatively recently. And when they diagnosed you, what was your Gleason score? Did they diagnose you through a biopsy?
Yes.
And what was your Gleason score on that biopsy?
Well, there were 10 9s and 2 10s.
10 by 9s and 2 5+5. So you were a 5+5. And what was your PSA at the time?
Well, it's not really sure, because I had a PSA on July 8th that was 9.59, and I just had a PSA that biopsy was done on December 24th. And so in early July, the PSA was 9.59. I just had another biopsy on January 21st, and it was 21.31.
Okay, so Jan 21st, 121.26, your PSA was 21, did you say?
Yes.
Okay. And that biopsy, and back in July, it was 10. Is that correct?
Yes.
Okay. And the biopsy that showed 10 9s and 2 5+5s was done in December. Is that right?
Correct.
Okay.
Correct.
I'm getting it straight. We'll get into the weeds in a second. Where did you have this done?
The biopsy?
Well, I guess who's your main doctor? Who's the doctor that's telling you to get a biopsy and get a PSA test and what have you?
Well, it started because I had increased nocturia and hesitancy back in like May of 25. So I saw a family physician, and he's the one that ordered the PSA. When the PSA was elevated, he said you should see a urologist. So I saw actually a urologist physician assistant who could get me in sooner. And she said, well, we ought to do an MRI. So I had an MRI in November and found PIRADS grade 5. So biopsy was recommended, and I had a urologist do the biopsy December 24th.
And where was that urologist?
Silverdale, Washington.
Okay, so they were in so it's a local community urologist who you're seeing at this point.
Yes.
Is that right? Since you had this biopsy, has anybody scheduled a PSMA scan for you?
I had that on January 21st, I think.
Okay. And what were the results of the PSMA scan?
Well, succinctly, metastatic disease. There are like three thoracic vertebrae, three thoracic vertebrae involved. I think there are 3 ribs and possibly something in the ilium.
Okay. And who is your current lead doctor and what is being recommended?
Current lead doctor is Stephen Blinka at Fred Hutch, and recommending relugolix because I have heart issues, abiraterone, and prednisone.
Okay. And what sort of doctor is Dr. Blinker? I don't know his name. I do know some people at Hutch. Is he a genitourinary medical oncologist?
Yes.
Okay. All right. And so how many, it seemed to me like you had 9 or 10, you had 3 thoracic, and then you had something in the ilium. Where were the other ones? Just recite those again slowly.
Well, I don't remember it in detail.
Okay, just tell me what you just said.
Yeah. Well, my recollection is 3 thoracic, 3 ribs, and something in one of the ilia.
Okay. So it's so weird how this happens, but you're a little older than Michael P., but it's very similar to Michael P. Right now we think that there are 7 in the bone. Did they see anything in the lymph nodes? Did they see anything anywhere else?
They talked about something possible in the sacral area, and I think there was a possible node, but I don't remember.
So, and if they're concerned about your heart, I'm also concerned as to why they're putting you on abiraterone. Was that discussed?
Yes, to some extent. Well, I think there was a what's it called? Darolutamide, I think.
Yeah, darolutamide.
Darolutamide. That was mentioned as a possibility, but according to Dr. Blinka, if I took that would take me out of future clinical trial possibilities.
Okay. So I think what you're going to talk, can then somebody look up Dr. Blinker for me whilst we're doing this, and let's find out if he's young, if he's old. He's not
he's
a
young.
name that he's young.
I'll tell you, he's young.
Okay, so it's amazing. It's the same story as like Dr. Keegan. Why is he concerned about clinical trials when he's starting to treat you? What we want to do right now is get you on the best possible therapy. And the best possible therapy for a man with heart condition is not abiraterone, because we know that abiraterone can cause heart issues. If you are healthy, great. When I say healthy, if you didn't have but if you didn't have CVD issues, yes, that would be your guy. And that would be your drug, abiraterone. But if you have CVD issues, we know that you're better off with a different drug, and these younger doctors don't get it. And they're sitting there trying to become a star so they can get people into clinical trials. We don't need to worry about clinical trials just yet. There's probably 6 or 7 different treatments we can do for you, even if we start you off on darolutamide. So, you know, it leaves me a little bit speechless. So, what I would do if it were me, same thing as I said before, I try and get yourself a more experienced doctor right off the bat. Dr. Schweitzer, Dr. Chang. Those are the doctors that we would recommend you see at Hutch. Larry Fong, a fantastic doctor who doesn't have a very big clinical load, and he's one of the best doctors in the country, but he's basically a research doctor. He knows us. He's on our advisory board. And I trust him. I trust him as my doctor. So
is he at Fred Hutch?
Yes. I know him.
FONG?
Yes, I'll put his link in there. But he doesn't. He sees. We've got a lot of people who are falling asleep on here. I must be really boring. Really boring. Oh my gosh! Look at this! Look at this screen. This is embarrassing. Steve Lodge.
We all experience fatigue.
I know you do. Steve Lodge. We'll talk about abiraterone in a second. I'm going to give us maximum another 10 minutes on this, maximum. But Steve Lodge, you want to talk about Dr. Fong? Because we switched you to Dr. Fong.
Yes, I appreciate Dr. Fong very much. I communicate with him well. I do, you know, he is heavily into research, and you know, I'm not sure exactly how on top of all the current protocols he is, but I'm staying with him, and I appreciate him very much.
And who would like to talk a little bit about the right choice of drug if you have CVD issues?
Well, I'd go with darolutamide. Like you, Rick, I don't understand why this doctor is concerned about future clinical trials. You know, why not treat Harry with the best possible treatment right now? Because he needs that.
Yes,
Okay.
Now, I am going to put a link for Dr. Fong in the chat window for you. You can whoever it is, you can tell him you know you feel comfortable with a much more experienced doc, and that you are referred by AnCan, because Dr. Fong knows who AnCan is because he's on our advisory board. He was one of the very first doctors ever to discuss or to innovate immunotherapy for prostate cancer. Jeff Markey would like to talk to you about heart issues.
Yes, I was on Abby for 2.5 years. It caused me, I never had high blood pressure in my life. I'm still taking pills for high blood pressure today because of being on Abby. It gave me high blood pressure within a matter of months. It also caused me to have 4 atrial fibrillation problems. One of them put me in the hospital for 4 days. Abby is not the drug if you have heart issues.
Okay.
And you know, your doctor knows something about that because he said, I'm going to put you on Orgovix rather than put you on Lupron or Eligard. So it does make me wonder a little bit why he goes half the distance, but he doesn't really go the whole distance. Have you had any type of genetic or genomic testing?
No, but I'm planning to.
Has your doctor discussed it with you?
Well, actually, I've seen two medical oncologists, one at Swedish and the one at Fred Hutch. And the one at Swedish leaned more on the genetic testing, and I'm planning to have the genetic work done there.
Well, I would not recommend that. I mean, let me go back to RJ. RJ, what's your feeling on splitting treatment between Swedish and Hutch? Because you're kind of, you've been in that boat a little bit, right?
Yes. Yeah, and Steve as well. And I will say it takes a lot more effort because I am pretty much responsible for coordinating my care. And I feel comfortable with that. But if you can actually have the docs talking to each other, I mean, they can see the stuff in my chart going back and forth. So they see the test results. And if they take the time, they read the clinical notes. But if you can just have one team in one place, and the place to go is Fred Hutch, that makes it easier on you. I would say for me, you know, because of the radiation oncologist and the way that kind of like my whole journey unfolded, I set it up and I started out at Swedish. And, you know, like I went to see, you know, my primary care guy is still at Swedish because I live in Redmond. And so he's like 10 minutes down the street. And then I went to see the urologist, and then he signed me up with the surgeon and I went to talk to the medical oncologist. And then eventually I talked to this group and they said, well, you know, go talk to Schweitzer and he's really good. And, you know, but, you know, if I actually had the whole team in Fred Hutch, it makes it easy. You know, I will say when I go in, you know, for visits, or particularly when I go in for chemo infusion, like they got it all down. Like it's just like one thing after the other, and they just go in a line. So it does make it easier. But, you know, if you want to coordinate that and you feel comfortable with that and can get the support and, you know, other people, and we have people here that are in both Swedish and Fred Hutch and can help you navigate those waters, like Rick was saying, those connections that happen after the meeting because the meeting doesn't end, then that's something that's up to you.
Right.
Okay.
So let me just say, in the interest of, because we got to be moving on. Number one, reach out to RJ, use the chat window, send him a message, reach out to RJ, reach out to Steve Lodge. If it were me, I would not separate, I would not split my treatment. I would be at one place. If Dr. Blinker has not discussed any of this testing with you, his bad, he should have done.
Well, we did talk about it.
Okay, well, I asked, that's why I asked before, and you said, well, no, the guy at Swedish is doing it, and that's how we got into the Swedish. So you need, let's just say this, you need that testing done. You need the germline, and you need the genomic testing. So we'd suggest you do it.
Okay.
If it were us, we would do it, Harry. We'd do everything at the same place, because it's going to be easier in the long run. Also in the long run, you may not be a good candidate for chemo, but the same thing we said to Mike to Michael that you really are a high volume guy, and chemo may be on the table, but maybe your other health issues take it off the table. And you also need to be discussing radiation to the primary with somebody
Yep.
there.
See a radiation oncologist Thursday.
Okay. All right. So.
And bone care, because he's got bone mets.
Oh yeah, and bone care, and exactly
Yep.
the bone density. So keep talking to Dr. Alfredo. He'll guide you through and tell you where you need some more help. You can keep coming back to these meetings. Make sure we have your email. I don't think you sent it through yet, but please send it through so you know when the next meeting is, and contact with some other
I don't
people.
know how to send it through, so.
Okay. Very quickly, very quickly, Jeff.
Yeah, I just wanted to mention that abiraterone can cause a lot of fatigue, especially with prednisone. Darolutamide does not do that. It is has the least side effects of any equivalent drugs. You would really much prefer it if you try it. You also get a lot more hot flashes on abiraterone. Some things to think about. The darolutamide is just a great drug. I've been on it for 3 years.
Okay. And
Okay.
Steve Schuler's also asking, he's another guy in your Seattle area. Have they done did they do a bone scan? Did they do a bone density test on you? Have you had a bone density test? DEXA scan?
Not yet.
Okay. So are they scheduling it?
They will when I bug them tonight.
These are all the things. Now, my guess is that if you were seeing Dr. Fong, all of this would all be bup, 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 and they're all there because he knows his way around. So bottom line, if you're going to stay at Hutch, you need to switch docs. Dr. Fong would be my choice. Dr. Schweitzer's another choice. Dr. Chang is another choice. So there you got 3 right there. I would not, based on what I'm hearing tonight, Dr. Blinker would not be my choice. Can't take it. No more questions on this. Sorry, Steve. Steve Roux, put it in the chat window. We got to move on. If we got time at the end, we can come back to Harry. All right. Let me get my list of people who need time.
Okay.
Oh, must be here. Yes, it is here. Okay, just bear with me 1 second because I need to make a couple of little notes, Michael. That's really weird that Michael P. and Harry W. are really very similar issues. If I put similar issues, this is why we like to get to you before they give you a GU Med-Onc, because we can help you with that. All right. Joe, no, wait a minute. There was somebody who didn't. RJ, you've had a little bit of time already, but RJ, we missed you last time. You dropped off. So please, we'll start off with you.
Okay, sure. Just a quick update on me. So last Tuesday, so I missed last Tuesday's session because I was in chemo getting my infusion at Fred Hutch, session number 4. It's going okay, I will say today. So today is day 7, depending on how you count. And mostly I just have fatigue now. So it's like when I stand up, and try and walk across the room, I'm getting out of breath. And so mostly I would say the brain fog is lifting and I want to go do stuff, but my body tells me that I can't. And so I listen to my body, and by now I've figured out how to do that. I will say everything else is going fine. Like the proctitis that the chemo made worse from all the radiation that I got. I figured out how to, deal with that. And even the one thing, I don't have any neuropathy, but like on my fingers, I was getting like all of these, cuts that were kind of like just opening up, like the skin would just like split. And one of the things I realized with that is I got this like Gold Bond like overnight lotion. Probably any lotion would work. I ended up slathering it on, and then I just put on these white cotton gloves that you can get for like $1 a pair on Amazon. So if anybody runs into that issue, and it's just kind of like, well, like I don't want to fall asleep with, this lotion all over my hands and get it all over the sheets and everything. Like that was one thing I discovered, and so like that's perfect. So the finish line is in sight. Like I'm just gonna do session 5. Keep my fingers crossed for session 6, and then just coast. My plan is to coast. I haven't been getting a lot of exercise. I exercise when I can. Like my plan, for year number 2, because I'm finishing up the chemo in March, which will be my anniversary from when I had my biopsy and like found out about all this stuff. Year 2 is exercise and diet and coast for as long as I can. So that's where I'm at.
Okay, and you're done now with you're done with your RT. So there's a lot of good stuff. Have they done any scans or any testing since you started all of this regime?
No, just every 3 weeks when I go in for my chemo, they do a PSA. And it's undetectable. So at this point, they're kind of like, it's just like, well, how do you know the chemo's working? It's just kind of like, well, it's keeping me coasting, that's for sure. And so that's the only thing. And then of course they do all the blood work. I already had the DEXA scan done. I already had my somatic and my germline, no mutations there. So I'm doing everything that I can for right now, and then I'm just going to coast as far as I can.
When do they plan to do the next PSMA?
They didn't say. I imagine that, I might do some sort of a scan this coming year. I don't know if it'd be a PSMA. I had it done at Seattle Radiology because that's like a spinoff from Swedish, and they screwed up the scan. So like, especially this is one of these things where, okay, like the people talking from the Seattle Radiology to the Swedish to the Fred Hutch, they can't figure out what kind of scan I got done because they got that all confused. So I might end up getting a PSMA just because Schweitzer is convinced that I did not have a PSMA PET scan because when they sent the original scan over, it said it was the oxumin. So he's like, well, like you didn't get a PSMA PET scan, so I might get that done if I can.
I think you should ask him for one, so that we know and be your own best advocate. You certainly should have had a PSMA before they started treating you, and if you haven't, then you definitely need one. Anybody have anything they want to say to RJ other than the fact that he has the best head of hair for anybody who's done 4X chemo that we've ever seen? And if that's not an endorsement for cold caps, nothing is.
Yeah.
If you can get the data file from the original radiology lab that gave you the scan, it has all that stuff on it. They'll give you a CD or a DVD, I guess.
Yeah,
that's a
suggestion.
Good point. Yeah. There is an addendum note on there where the radiologist that read the scan said this has to be PSMA PET scan. I think there was a discussion last week on like what shows up in the kidneys, and the radiologist that reads that can actually tell which scan it is.
So reach out to them and share that with Schweitzer, and let's find out if you had a PSMA. That's your homework for the next meeting, to come back and tell us, did you have a PSMA or did you not have a PSMA? The other part of your homework is you and I have to talk to each other. I did try to call you, but your system didn't let me get through to you. So I left my number, but you maybe didn't know, but we'll talk. Now, Michael P., what can we do for you?
I just wanted to thank everyone. I need to leave the meeting. I did post a note with respect to my homework assignments, and I'll be following up with you all, as soon as I have something of any
Okay,
consequence.
well,
Probably
come on in
meeting.
anyway. Next Tuesday. Come on in next Tuesday. That's when we're at. And it's an earlier time. Watch the.
Okay.
Be sure you know. All right, I'm moving on.
Thank you.
I'm keeping rolling. I'm keeping rolling here. And Joe Commander, you're up.
Okay, I have two questions. The first has to do with exercise. My daughter keeps pressuring me to change the way I exercise. And what I'm doing for exercise is what my physical therapist recommended. She recommends stuff that there's a program called Starting Strength that maybe you've heard of, but maybe you haven't. It's basically sort of real heavy weights like you do if you like 50 to 100 pounds, maybe more, I don't know, with these big lifts and all that. Any thoughts from anybody about what they do or what they think is good or not?
So what I would suggest you do is check in the Philly area and see if there is a Live Strong program at one of the Ys.
Live Strong? Yeah, there are.
Okay. Then if there are, I would enroll yourself in that Live Strong program for 16 weeks. And at the end of that 16 weeks, we'll talk about what to do next.
Okay.
Because I think they know better. They have these specific programs that are really tied into people who are living with cancer, and they know their stuff. And I think it's a really good way to go, rather than trying to design your own exercise program, or frankly, having a physical therapist who is not a cancer expert. If you're with a specialized trainer who has a qualification in cancer, that's one thing. But the physical, otherwise, I don't think that they're as good. And I think these programs are free at Live Strong, and that's what I would do. Anybody on here had any experience going through a Live Strong program?
Steve here.
Steve Lodge.
Yeah, I have signed up for it. It takes a while to get in their system and get a class started. It'll be about 4 months for me. But yeah, it sounds like a good program. I hope it works.
Okay.
Okay, so I think it varies. I mean, I've known people go in and start the next week. I think it really depends where you are. Russ Seneca.
Yes. There's so much controversy about what to do, but for us older guys, lighter weights, more repetitions. But the answer is you got to get to fatigue to build muscle. But for me, more repetitions with lighter weights makes a lot of sense for us. We're not trying to bulk up. We're trying to maintain what we have.
And Dan in Schenectady.
Yeah, I also signed up for Live Strong program. I was a little frustrated because it takes so long and it doesn't start till April. But I'm hoping to get some benefit out of that program.
Okay. So, that also might be a factor, Joe. It depends when they have a new starting class, and that could also cause the delay. So,
Well, I was going to arrange to get a DEXA scan, which should tell me, the last one I took was before I started hormone therapy, and it should tell me whether my exercise has been working, right? I think. Okay.
Yes.
All right. The second.
What's your other question that you got?
Yeah.
For
The
us?
other question has to do with the what we what I listened to on Saturday, this presentation by the people from NIH. I got really excited, whether I should or not, I don't know, but because before I started ADT last September, October, I would have fit very much into the category that they were defining, PSMA plus whatever it is. So I contacted them. I actually emailed them Saturday and heard back from one of the doctors today. And I'm thinking about doing a consultation with them and wondering whether it makes sense to go back off the stuff. I don't want to do anything too hasty either. I'm contacting my regular medical oncologist, who I'll see in a couple of weeks. Any comment?
Who is that? Yes, I
That's
do.
Dr. Pooja Gatalia from Fox Chase.
Right. So I do have comment. I think that there's absolutely, as long as they're willing to talk to you, I think that it's a great idea to talk to them, either Dr. Abel or Dr. Madan, whoever's willing to talk to you. They both impress me. They have the data. And a lot of these docs, like Catalia, will not have the data. And so they'll be talking without the data. They have the data. Now, I would not raise this with Dr. Catalia until you've spoken to NCI. The reason being that part of the job that they do is they talk to your doctor.
Oh.
And it's much better coming from NCI than it is coming from you, because you're not going to be able to argue the case. So if you and Dr. Abel, for example, think that you are a candidate to come off the medicine based on there and take it. How long have you been on it now?
15, 16 months or something like that on ADT. And
Right.
on the other one, it's Nubeca. It's only been since October this past year.
You know, you're the sort of person that is probably right in their sights.
Yeah.
In their hairs. And yes, I mean, if they think that you could be feasible for this trial, you know, it's a hop, skip, and a jump for you to go down one time, to Bethesda, and after that you can charge him for gas every time you go down. So it's even better, right? So I would say I'd encourage you to do it, and we'd love to hear how you do with them. But you saw the video. I mean, those guys are pretty aggressive, and they're not going to lead you wrong. That's my feeling.
Yeah,
that's my feeling. I had just for everybody's sake, unrelated to the video, I had a discussion with Dr. E today. And I told her, you got to watch this, E, because she's been treating this way for a long time. This is how she treats, you know, she do no harm. And I just think that it could be the way of the future, and it's going to take us a long time to get to that point. But I'm glad it's already helping our guys. So yes, and they'll do that. They'll do that first consult with your video.
Right.
So what you got to lose, Joe?
I don't know. My chains.
All right. I'm going to keep going. Any questions about what we've discussed with Joe? Okay. We keep going. We keep going here. We keep going. Dan in Schenectady.
Yes. And just for endocrinologist pronounced Schenectady.
Schenectady, sorry. My bad, I should know that as a former New York area person. Schenectady, yes.
Yes. Just to update, I got my first shot 6 months of Eligard, and from my local urologist, and he told me he's retiring in May. And so I called a urologist who did my surgery and asked if I can start seeing him. He only does surgeries. And so they made an appointment with a nurse practitioner in that practice. And I'm wondering, is that normal to happen?
Look, this is, first of all, did you get another shot from
Yes.
the guy who's retiring? Because you've told us before that he was retiring. Did you get a shot from him right now?
Yes, I got Eligard
When did you get that shot?
today.
And how long a shot did he give you?
6 months.
Right. We've told you guys time and time again, don't get 6 month shots. Sometimes I think we talk to ourselves. Don't get 6 month shots. And I know we've told you, Dan, because he gave you a 6 month last time. We said, don't get another 6 month shot.
Because I got confused because I must have got confused because I was under the impression that you said to get a 6 month shot because I had 3 months before.
No, we told you, don't get 6 month shots. We've never told anybody here. What happens is they tend to wear off not for everybody, but for some people, they tend to wear off. We don't like 6 month shots. 2-3 months is what we told you. And there's no point, and you don't need them for anything else. You're seeing Dr. McHugh, right?
Yes.
So you don't need to see a nurse practitioner. You don't need to see a urologist. You don't need to see anybody. Dr. McHugh is managing your hormone therapy.
Gotcha. All right.
All right. And we don't even want you on that. We want you on Orgovix, but you couldn't get onto Orgovix, correct?
Yeah, it was never offered to me.
I thought you tried to get it and not. So again, get onto Orgovix if you can get on Orgovix. You're a veteran. Between now and the next time you need a shot, figure out a way with Jim Marshall's guidance to go into the VA and get Orgovix. You'll have enough time to do it. You'll need a urologist in there. You'll need a GU Med-Onc, but you can get your Orgovix through the VA.
And just from my knowledge, so I go to get Orgovix for VA. Is that offered through private medicine? Medicine is just easier, or is just more cost effective to get through the VA?
It's offered through private medicine. It's going to cost you more if you do it with your regular Advantage or your traditional, whatever you've got, traditional Medicare or Advantage. You have one of the two, right? What do you have? Traditional Medicare?
I have Blue Cross Blue Shield.
Traditional or Advantage?
I'm not sure. I get it from off my wife's insurance.
Okay. Either way, it's probably going to cost you more, number one, and number two, they may not approve it. We don't know. All right?
Yep.
So, but that 6 month depot, not a great, in our view, not a great move. It's going to work. It's going to do the job, but you need to be getting you need to be getting, and you're doing this with, I forget, abiraterone or darolutamide?
Abiraterone.
Okay. You need to be checking your PSA, your testosterone and your PSA in month 5 and month 6 for sure, if
Okay.
not before. Keep an
Okay.
eye on it just in case it's not working.
Mhm.
Anybody want to say anything or before we move on? Okay. True for everybody. Stay away from 6-month depot shots, please. We've seen them not work. And then people don't understand why their PSA is doing all strange things in the 5th month and the 6th month. And then they check their testosterone and they find, oh, that my testosterone's high. Well, why was that? Well, I got a 6-month shot. Well, those 6-month shots aren't so good at the back end. And there's no reason to get them other than the doctors like to give them. They may make more money on it. I don't know. And if you've got a GU med-onc, you don't need a nurse practitioner. You don't need, if you've got any issues, take him to Dr. McHugh.
All right. And I see him Thursday, so so I'll talk about I'll see if I can get on Orgovitz.
Tell him you just got, and you'd rather be on Orgovix, and can we do this for the next time it comes around?
Okay.
Okay. All right. I'm going to keep rolling on here because we still got a bunch of people. So, John G. in Southern Florida.
Everyone, just had to get the mute off. I'll try to go quick because we're behind time. I'm about 1 year post treatment with radiation. I'm getting side effects. I noticed Saturday I had blood in my urine. It was maybe hematuria, like a long string of blood, like a strand, like a thread. Pretty worried about it. So I went online and it made me even more worried. They were like, you got to go to the emergency room immediately, blah, 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 blah. I resisted because I didn't want to go to the emergency room. So I called my, the oncologist today. They're going to, I'm having my PSA tested in about like 2 or 3 days. So they're going to check my urine then and maybe talk about doing a cystoscopy. I'm wondering if anybody else has experienced this, how serious it is. What I should look for. I'm worried it might be an indication that the cancer's coming back. That's what I'm really worried about. I can still urinate. It's just, a little bit more difficult, but I have just that one strand. And that's it.
Okay,
So just worried.
when did you finish your radiation therapy?
Like March last year, so it's about a year.
Okay. Most likely it's not the cancer coming back. And guys, please resist the urge to go to Google because you don't get the best information. And especially if you're the anxious type, it can make you crazy and nuts. Highly likely it's radiation cystitis. Most of us have had it at some point or the other. Look, Frank's even serenading you there on the radiation cystitis. It's most likely radiation cystitis. I went through it 3 times, and because they wanted to do a cystoscopy, I can't give you medical advice. If it were me, right, I wouldn't do a cystoscopy. I would cystoscopy right now, negotiate. That's what I did. My doctor said, okay. And happened 3 times. And he said, next time you got to get a cystoscopy. I said, all right, Joe, if you're saying it. And the next time, sure enough, I did get one. And when that happened, it turned out that there was a little bit of radiation cystitis. Okay. So if you want to do it, don't panic. I'm gonna let my expert here, Dr. John talk to you because he's got his hand up. So, and I don't know what Dan's talking to me about. We know you need a urologist, Dan. We know if you're going to get a Lupron depot shot. We've been through this. We've talked about it a bunch of different times. We get it. But just, that's all you need them for, to give you a shot. So let me move along here to Dr. John.
I agree with Rick that the chances are overwhelmingly that this is radiation cystitis. It tends to arise, and then after a certain number of months, or in my case, more almost 2 years, go away. It is seldom severe enough to cause anemia or symptoms that might require you to seek treatment. The treatment is hyperbaric oxygen therapy. The purpose of the cystoscopy is to establish the diagnosis and to make sure that the blood is not coming from something else, like something growing in the bladder or coming downstream from the kidneys. What you passed there was a clot. It was just a long, thin clot in the exact shape of your urethra. So let me turn it over to Russell and see what he has to add.
No, I agree 100%. I mean, one small episode does not require a cystoscopy. It's way over treatment, and I agree. It's got to be radiation cystitis, and this is about as minimal effect, I think, as you can have. So I would just chill out.
That's easy for you to say.
Yeah, but the thing is, we've all been there, John, and we can tell you, and we really have. And look, I mean, Lee, I'm going to come to you in a second, but in my own case, I'd had blood in my urine so many times from different things, usually from exercise and exercising too hard. And the last thing I wanted was something to stick something up my schmeckle to see what was there. As it turned out, it was a nothing. As it turned out, I didn't even have to worry about it when I eventually got it. But I must have gone for a year before I had it. And if you're the nervous Nelly type, it can make you crazy. And we got to take charge of ourselves on there. And that's another topic for Dr. John and Dr. Jack to talk to you about. We've got a speaking freely, gents. We've got a speaking freely this week on Thursday. I think Dr. John's is going to moderate. That's what we do in there. Talk about it in there, and we'll give you some techniques to try and help you with this. We can do that, can't we, Dr. John?
Oh, yeah.
All right, Lee.
Sounds good. I'll have my PSA by then, too. Well, thank you.
Yeah, I'll take about 30 seconds. Radiation in 2016, it's the gift that keeps on giving. I have had bleeding episodes off and on for the last decade. They will last an hour, a day, 3 days. They come, they go, and it's just something we got to live with after radiation. My last one was 3 or 4 months ago. I'm on an indwelling catheter. I woke up in the morning and I had a bag full of blood, the bed bag. That was it. Emptied the bag. Everything's clear. Been that for the last 3 months. It may be 2 years before my next episode. It may be tomorrow. Get used to it.
Thanks. AI just made it sound so dire. Oh, you got to go to the emergency room immediately. Like, yeah, you really have to be careful.
Well, that's why it's like it's out of control because you can't interpret the information. That's why we don't like AI. We don't like Dr. Google, because unless you know what you're reading, it's giving you it's telling you the wrong stuff. Okay.
They have to be very careful. They have to be overly
Not be your
conservative.
first place. Wait until today and ask us, and then it's worth it. It's worth it. It's worth it. Somebody who yes, Frank.
Yeah, John. I've been dealing with this for a long time too, long time. But my best friend that I found is water. Keep pushing the fluids, man. I think that's what's keeping me not bleeding anymore. And I had a really bad episode. I don't know, a month and a half ago, 2 months, and yeah, I had my buddy Bag walking with me too, you know. And then they scoped it. But anyway, you're not even there, okay? Just don't panic. Yeah. It's natural. Just chill out. I mean, it is something that you worry, man. Shit, you start pissing blood. You're like, hey, it's like you worry. Is it more cancer? But it probably isn't. It's just So it's just your bladder gets burns on the inside from the radiation. Then there's like scarring in the wall, and that's why you have to keep the fluids in there. And when you get dehydrated, were you dehydrated?
I might have been, yeah.
Yeah, so keep yourself hydrated. Yeah, that's so. Anyway, you're good, bro.
Tony. I'm gonna excuse me. I'm gonna pass over you. I'm gonna go to Len, and then we're gonna move on. But I want to do one thing in the interim. Can everybody who has had some radiation cystitis put up their hand in the chat window, one or the other? But I'd like to see how many people here have had radiation cystitis. And you can either put up your hand in any place. Okay, well, we're up to 6, and Sylvester's had it. He's got his hand up in the window, and we got how many now? 7. It keeps going up. We've all had it. Len, what do you have to say?
I just had a question for John. When you put your info into AI, did you put in all the info? Like you had prostate cancer, you had radiation a year ago?
Yeah.
You did?
Yeah.
Okay. I'm just surprised that it gave you such a crappy answer, because my experience with AI, frankly, has been pretty good. But
I think it was just overly cautious, and just like when I said that it was just a thread, they thought it was like a worm, you know. And then I was like, no, it's not a worm, it's a thread, you know. And when it was, then they sort of mellowed out, but they're like, still, you got to get your blah blah blah, call your oncologist first thing, blah 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 blah. I was just a little worried about it. I did call, and you know, they were like, yeah, we'll take a look. So I just wanted to double check with you guys, because I thought I might get a response like this. It is
all
nice
right.
to hear. Anyway, thanks, guys.
Okay. Jerry Pelfrey.
Okay, I'll be real quick. You all, Rick, you mentioned it. My question is simple. How do I get a hold of Dr. E at OHSU? I have changed my all of my portal information from Methodist to OHSU. And I got to tell you, the people at OHSU don't know anything about Dr. E. They don't have a list for her or anything. The only way one person there helped me was that they went out on the internet and read the Portland news that said Professor Estapatu was a professor now at OHSU.
So let me answer you. First of all, she told me last week she is answering her emails she sees her emails from Houston Methodist. So the first thing is I suggest you
I'll email.
Houston Methodist.
Yep.
All right.
Yep.
The second thing is I'm going to give you right now, so I don't forget, I'm going to give you an email to use. I'll send it to you privately in the chat, and use this email and in the email say you've been trying to get hold of her and you need to get her, and you'll hear back from her. We did this with for Julian, and it worked. So hopefully this will work for you. And
Okay.
I'm sending it to you right now.
Good. Thank you. We did a Tempest test in December, and we didn't get a chance to talk about the results. And she said she'd call, but of course, you know, she's busier than hell moving and all of that stuff. So I want to get to her so we can talk about me going off at least one of my 2 drugs.
Okay, so
anyway, all right. So thank you. I'm done.
That's what did the Tempest test say? That's more interesting to us.
Well, when I started, the first one I took, I've had, this is the third one. First one I took said I have 0.08 red blood cells going through my blood. The second one said 0.06, and this one said 0.08 again. So still relatively very low. And actually, I'm of the opinion that I think there are people walking around that don't have prostate cancer that have that many cancer cells going through their blood. But that's why I want to talk to her, because I'd love to get off Orgovix. My osteoporosis, I'm fighting hard to have it not get worse. And so I'd like to, like Len, just be on Nubeqa. And I'm even considering taking a vacation off Nubeqa and just, you know, I've been on all this stuff for 7 years now. So anyway, that's why I need to chat with her.
Okay. Well, I'm sure that she will be quite empathetic towards monotherapy Nubeqa darolutamide. Okay. And guys, I ask you all the time, please don't message me with private messages in the chat when I'm moderating. It's like, hello. Sorry, but honestly, I mean, I'm keeping notes. I'm trying to run the meeting, and I got people. It's like, use your noggin. I don't know what to say. I can't read, and I certainly can't answer you. It's impossible. How many things do you think I can do at once? It's stupid. Okay, so let me just say needs to speak to E-Ray Tempest. But to me, it sounds really good, Jerry, that you know, you're pretty stable. And that's what we want. We want to see you stable, man.
Yeah, my PSA has been this last time with my Med-Onc here, we did a more thorough PSA. I forget what they call it.
You don't need a more thorough PSA.
Oh, I know. He just did it. I didn't ask for it.
You know, so it doesn't mean anything. It's not relevant because in your situation, it tells us nothing. And then what happens is you get another one, and then you'll come back and say, "Oh, my PSA's tripled since last time."
Oh,
well,
no.
no, not exactly, not exactly. You know.
No. My regular PSA has been below 0.01 for 2 years.
There you go. Okay. So let's drop that PSA discussion, and I think you're doing. I think you're doing great. Now, I will tell you that there is an issue that Dr. E is working on, but in Portland, all of the nurses are unionized, and that makes it very, very difficult for them to do video calls in Oregon. And she's trying to figure out a way around it, but it's a problem. And we're having some discussions. And one of the things that I will be coming to you all about very soon, probably through the reminder and maybe in here, is I want to get some feedback on how you feel about video versus personal calls. We're not doing it tonight. We don't have time, but I will be looking for feedback because we don't know enough about how patients feel about video versus regular calls. Okay, now let me see. I've got, whoa, this isn't as bad as I thought. It's only just 8 o'clock. Look, we haven't had too many people drop off. And I think the only person, I've got 2 people. I've got Steve Schuler, who I'm coming to in a minute, and Steve Lodge, who I'm coming to right now. Mr. Lodge.
Yes, good day. Well, with several other people, we've heard the advantages of Orgovix over Lupron for people with heart issues. And I'm just wanting to confirm that that's pertinent to me. I had a triple bypass, open heart triple bypass about 5 years ago. Cholesterol issues associated with that, and high blood pressure on and off all my life. And now we're having trouble controlling the high blood pressure. And so I'm just wanting to confirm that for most thinking Orgovix would be superior for Lupron for me.
Go ahead, Jim Marshall. I can hear you already. You're chomping at the bit. Go on.
Chomping at the bit. I've got all of those, and Lupron's definitely out. I mean, it is not for people with heart conditions. Okay, I've also got AFib, and I've got a screwy EKG, QT, and QTC interval. And abiraterone says if you have this, don't even think about it. So it's great justification. And so eventually I will be probably back on the drugs, and it won't be those. So
anybody else want to recommend a ADT based on their own experience to Steve Lodge? Any other hands? Whose hand is that? 2. We've got Russ, Dr. Russ first, followed by, I don't know who, but you go first, Dr. Russ.
Well, I think if he's had bypass surgery, then indicates an underlying atherosclerosis. And I would agree. I don't know why. I would strongly suggest switching to Orgovix, but I would like to hear what Dr. John thinks about that. Or
that was our other resident expert who had his hand up, Dr. John.
I was thinking back to last summer. I think Steve and I talked about this, and I think even a cardiologist? Steve, did somebody tell you that they didn't agree with that and wanted you on Lupron instead? Wasn't it even a cardiologist or something?
Yeah, actually, when I first brought it up to Dr. Fong, he wanted me to stay on Lupron, stating that Orgovyx was a very new drug, and we didn't know a lot about it. But yeah.
What did Dr. Effie have to say, or haven't you seen her yet?
I never saw that person.
Well, we recommended a cardio oncologist to you a long time ago, Dr. Effie Andropoulos.
I did see a person with that specialty, and I didn't ask specifically about that Lupron, but she didn't recommend any changes to my cancer drugs. She did recommend some changes to my heart drugs.
That's exactly what I remember now. It's bringing it all back to me. And I was a little surprised at that. We think that it's not 100% proven, but we think that there's enough evidence that you're better off on Orgovyx to do it because there's no downside.
Yeah.
And you were even once on abiraterone. I don't think you're on that anymore. And we also talked about when would be a good time to actually take a break off these drugs. And I can't remember if you're eligible for that yet or not.
We've talked only slightly about it. My PSA has been rising for the last 6 months or so. So it's not considered a good time to get off.
Okay. You were up to 0.3 last time we talked.
Yeah, most recently about 0.53. But
okay. All right. Not a good time to take a break, no.
Have you guys confirmed what I thought, so I just need to be able to argue it a little stronger every time. Thank you.
But what about if you're now at 0.53? What about doing a PSMA scan?
Yeah. With that number, they wanted to wait a few more months.
Wait a minute. With 0.53, they wanted to wait a few more months?
Yes.
That's what Dr. Fong wanted to do?
Correct.
Okay. But, I would say at 0.53, you're going to see something. But anyway.
Yep. They anticipate it being up the next 30 or 90 days after the last one, and I believe they anticipate doing a PSMA then.
Okay. Well, anybody else have anything for Steve Lodge before we move along? Okay, well, I missed Steve Schuler because he put a message in there that he was leaving around 8 o'clock at 7:56. He was moving on my time, so I'll send him a note and tell him to come back next time. Is there anybody who wanted time who I did not speak to? Use the hands up function. Well, Dr. John and Len, we're only 8 minutes over, and we got through everybody, but Dr. Russ has his hand up.
Yeah, Rick, I just wanted to thank you for arranging that talk by Dr. Madan and Dr. Abel. It was fantastic, and I'm big into confirmation biases, and I think that's what we look at TVs that we confirm what we think, and they were spot on for me. Whether you call it adaptive therapy or whatever you want to call it, but I think overtreatment is so rampant, and I agreed with it, and I want to thank you very much for getting that together.
I mean, it was a pleasure. I mean, I didn't expect it to be as radical as it was. I mean, I've heard a couple of people say adaptive therapy. I mean, adaptive therapy is a little, as I understand it, is a little bit different, but it's kind of a vague term. You know, there's that fellow, what's his name at Tampa? I forget the medical oncologist at Moffitt, who's Mr. Doctor Adaptive Therapy. This is to me, this is more in lines with active surveillance and, you know, doctoring, as opposed to all of the different tests and the this and the that and the analytics that the guy at Moffitt is doing. I forget his name. Somebody must remember his name on here. Russ, go ahead.
You know what? I don't remember the article, but actually, when I first came upon him, and I don't remember his name either, it was in the Wall Street Journal, but he was comparing the treatment that oncologists do compared to a blitz therapy, and he was basically comparing what we should be doing to exterminators, the pesticide industry. So I don't know what would call it, but I think the idea that I heard on Saturday was great, whatever you want to call it. And I'm not saying I believe in adaptive therapy, but I think being reasonable and managing the cancer is a lot better than throwing grenades at it.
Yes, I found a video with him. What the heck's his name? What's his name? I don't know. I don't know. No, he's a different guy. I don't know. I'm sorry. Everybody at home who's listening to this is yelling at the screen. It's Robert. But I cannot. I just can't. I'm sure it's Robert something. I'm busy Googling here. Robert Gatenby. That's the guy's name. Robert Gatenby. He's Dr. Gatenby. He's the. Hey, listen. I remembered half of his name. I remembered the Robert. So, I'm putting it in the chat window for those of you who want to look it up. Gatenby. This is to everybody, everyone, and then we'll get it in the and here's his yes, here's his link for Moffitt, and you can do the rest of the. There's the heavy lifting for everybody. So now you can go from there if you want to figure out more about him.
He's actually a radiologist, Rick. He's not a medical oncologist.
Okay. See, this is what I know. Now you tell me. You couldn't tell me his name, Len. You forgot his name. Now you know what I'm talking, right? But now you know what I'm talking about, right?
Yes, indeed. And Steve down in Miami, if he's viewing this, he's going to say, Len, what the hell's wrong with you? You know who it is.
Yes.
You know who I'm thinking of, right?
Yes. And I still don't get this adaptive therapy. I don't. And I've had a couple of webinars on it. But I'm so glad that people found it helpful. I mean, we've all had probably over 300 views on this already, and we'd love to get it viral. So spread it to anybody you know, tell them to watch it. We want to get it viral for the sake of the people at the NCI who gave us their time, because they are not getting as much traction on this as they like. And I'm going to share with you, since Dr. John has now left, I'm going to share with you a brilliant question that Dr. John asked, brilliant, which we've taken out, we've taken off the recording of there.
Excuse me, Rick, you are still recording.
I know.
So should you shut it down or not?
No, I know. I'm aware.
Okay.
It's going through my mind, but I feel that this is not on the NCI video, and it's something we discussed, and I think we can discuss it. Don't you, Dr. Russ? You were there at the meeting. You're better at this than I am. I'll take advice.
Yeah, I think I would leave it alone.
All right, well then we will close the recording. Thank you for your advice. And I will then tell you all what was said. So we're signing off right now. And we'll be coming back to this. We'll be talking about this some more. Thank you. I appreciate the advice. And thank you, Captain Jim.